Hi, everybody. Welcome to Christmas Storm of 2022 and part two. We're going to start again. I'm Dr. Lisa Finkelstein with Beyond Telehealth and Telemedicine is Medicine. And Dr. Jaclyn Israel is here. She was driving through the rural roads of Maine and got stuck behind downed trees. So, Jaclyn, welcome. I'm glad you're safe. I'm glad you're here. Take a deep breath and introduce yourself and tell us where you are, what specialty you practice, and a little bit of your story. It's time to brag.
Awesome. Well, thank you for having me. Thank you for your patience as we navigate all that is rural medicine and weather in winter time. But either way, it's nice to be here to talk to you. So originally, I am from Southeast Michigan. I grew up in the Metro Detroit area. Went to the University of Michigan for undergrad, and took several years off trying to decide if medicine was really the right thing for me. And ultimately, that is where I ended up going. So I pursued my medical education at Michigan State College of Osteopathic Medicine, and originally thought my entire life was going to be spent in an urban academic center doing primary care in the city, until I had the opportunity to go practice up in Traverse City, which is farther north in Michigan. And that was really my first exposure to rural health and realizing how much of a need exists in rural communities. And then I also realized I was just a happier person out in more rural communities. So I really did a 180 and completely embraced rural medicine, which is now how I'm here. I currently am a second year family medicine resident. I am one of the, well, in the global picture of things, I'm a resident at Central Maine Medical Center, which is in a city called Lewiston. It's about 50, 60,000 people. It's kind of two metropolitan areas that are divided between a river. And there's associations with that main hospital in Lewiston, as a small critical access hospital in Rumford, Maine, 25 beds, all kind of comprehensive primary care. And that's actually where I am based out of. So I'm one of the rural track residents doing all of my continuity clinic work up in Rumford, Maine. And that's pretty much me.
Okay, so we have a lot in common because I lived also from Philly, moved to Michigan, and Wyoming was like a never state. I didn't even know where it was. So never say never.
Yep.
And I'm glad you're in rural medicine because it is a very important piece of healthcare, these critical access and these little tiny clinics and hospitals that don't have doctors and any type of ologist.
No.
So you are a PGY2, right? Resident.
Yes.
And you would like to do what you call full spectrum family medicine.
Yes.
Explain what that means.
Yeah, so full spectrum, the kind of tagline we have for that is essentially from birth till death medicine. And especially in rural areas, the need is massive because full spectrum primary care physicians, we deliver babies and do all the prenatal care for moms. We then are the PCP of the babies we just delivered and follow them all throughout their growth. We simultaneously are helping to manage our geriatric patients or our elderly adults and get them facilitated with hospice. We're going to do your chronic med management. We can do your MAT therapy if you need Suboxone support while recovering from your substance use. And essentially, we do everything short of surgery. However, there are specialists in the world of full spectrum family medicine who've gone on to do extra certifications in C-sections or cesarean section training for emergent OB or high risk OB. There's also people who've gone on to specialize or at least add colonoscopy procedures or stress testing. And really, the world's your oyster when you do this kind of medicine because we really fill the need of the community. Whatever is needed, we try to serve it, and they try and employ it all with just primary care doctors. So I love it. I find my day is never the same twice, and it just keeps you sharp, keeps things interesting.
Well, and I applaud you because you'll find it really, really rewarding. And because of that, I don't know, can you hear my dog barking in the background?
A little bit.
Yeah. Yeah, I'm gonna try to go if he keeps going. So because you're practicing rural medicine in that big spectrum, telemedicine is even that much more important. And that's where telemedicine originally started. And that's how I got interested because of days like today, where you've got these major storms coming in, where it's ice and it's wind, and you can't get to your patients. And telemedicine is a bridge so that that you can have access for your patients. So tell us why you're so passionate about telehealth.
Absolutely. And I mean, I think you really touched on a great point there. Beyond even just weather, I live in Lewiston, but the community I serve up in Rumford is a very low socioeconomic status community. And most of them do not have a vehicle to drive to the grocery store, let alone to the next big city or hospital that's over an hour, 2 hours, etc. away, depending on where they live. I have some patients who are so far out there that emergency medical services have already determined that they're inaccessible and cannot be picked up by an EMT. And so we're talking about people who have dire need for medical care, who we just can't physically even get to them. So if we could cross that barrier by just having them access a screen, access a camera, access a microphone, whatever I could do to be able to still gather a full history, be able to engage in as much of a physical exam as I can, that is game changing. And even on a more micro scale, if we just talk about the time, let's say we're dealing with parents and they have children, the time it takes from them to take off of work or potentially navigate childcare and the travel time, the cost of gas, the waiting in the office, if we can eliminate all these extraneous factors for people to really just get down to this is the medicine, this is the concern, this is how we're going to address it. And you never had to leave your house or your office or wherever you were performing this visit, that can be game changing, especially on days like today, but really just in general from a day to day standpoint. That's time, that's money, that's convenience, that's really what everyone's looking for in everything, especially in their medical care.
Right. And we now know 3 years later into the pandemic that telemedicine works.
Yep.
We are trying to figure out how to make it work better, to teach what we call digital literacy,
Hmm.
so that people understand how this all works, especially our older patients who struggle, me included. Um, but you can teach an old dog new tricks, and they want to learn. They want to be able to see their physician, especially if they and it doesn't even have to be rural. We know that if you're driving, in Philly on the Schuylkill Expressway or in Michigan and you're on I-75 and you can't get to your doctor, then that's almost just as bad.
Hmm.
So let's now. One of the things that you did mention to me, which I thought is another great use for telehealth, is taking care of patients in assisted living and nursing homes. That was one of my passions when I saw patients in this little tiny town of Pinedale, Wyoming. Give me your thoughts about how you think that looks in that type of facility, and why is it so important for telemedicine in assisted living?
Absolutely. So most nursing homes, assisted living facilities, skilled nursing, acute rehab, anything along those lines, the doctor's not necessarily in house 24 hours a day, but
Right.
the residents are. All these people are patients in this building for 24/7 care. And especially in long term care facilities, doctors may only be there once, maybe twice a week, especially in rural Maine. For example, the Rumford Community Home we have here, the medical director, who's the only physician employed by the system, is only there on Thursdays. So if something were to happen on Friday through Wednesday, um, she's not available. So right now we do not have a system in place to kind of cover those times from a medical need. So unless it is truly a complaint that can be addressed over the phone, those patients are coming to the clinic, to the hospital. And that is just not always the best. Well, one, for their safety, two, for their actual care. For example, we had kind of touched on this, but people with dementia, people who are in the memory ward, moving them out of a place that they have now come to know as home can be just as, if not more, distressing than the medical care they might need. And if I can provide that same assessment, for example, I might not be physically in the nursing home, but my nurses and my CNAs are. They can help facilitate whatever I need them to facilitate. I can give directions to help them, move a camera, change the lighting, get my vitals, figure out, gather a urine, do a point of care dipstick on a UTI. I can do all sorts of things, and they've never even left their rooms. Even more on a physical note, so many people I have are, dealing with complications of their very poorly controlled diabetes and now have bilateral below the knee amputations and they're wheelchair bound. And on a day like today, if you're in a wheelchair, just getting into and out of the building to be able to access the handicap accessible vehicle is going to be a journey, let alone the drive and getting out of it.
And expensive, Jaclyn. That's the
Yes.
other thing. Packaging up these patients to go even a mile
Yep.
is expensive and time consuming.
Right. And I have so many patients who aren't even in long-term care facilities, but they meet that qualification where they're wheelchair bound, stuck at home, need transportation just to come see me. And even if it's just to say your blood sugar is well controlled, you can continue your home meds. I mean, that's a journey just to have the conversation to say, keep up the good work, when I could have done that through this modality instead.
Right. So we talked about, I'm going to just bring up a couple terms because, a lot of people don't know the definitions of telemedicine, and I teach telemedicine to students. And one of the things is talking about synchronous telemedicine, which is like we're doing right now, real time, live, utilizing audio and video. And then there is the other type of telemedicine, which is called asynchronous telemedicine, or store and forward. And that's probably where things are going to head eventually. That's the model that Amazon is going to be using because it's convenient. So you just gave a few scenarios, and asynchronous telemedicine would be that the nurse or whoever it is, the MA, who are your hands, who you trust, are then taking a picture or sending information utilizing remote, what we call remote patient monitoring, which is the blood pressure cuff, the pulse ox, the temperature, the weight. And that information is then uploaded to their chart or to, whatever device. And then at your convenience, you're looking at that information, picture of a rash, picture of a lesion, and giving your expertise at an asynchronous time. So it's all these different things on the spectrum with telehealth that can work, but the point is it's convenient, right?
Oh yeah, I think that would be so different on the spectrum of a provider's life. We've all, heard the term burnout, but especially over the last couple of years in healthcare, most specialists, most departments are stretched so thin that people haven't actually grasped the concept of how hard everybody's working, the number of jobs they're covering. At my hospital, for example, there should be 7 full-time family medicine physicians who are doing full spectrum care. We've only had 3 since before the pandemic started, and 2 of them are about to leave because they are so stretched, so exhausted, and so burnt out. To their credit, I mean, one of them is just like, I want to be able to go home and be a mom to my daughters, and I've hardly seen them grow up. And to know that you could still have a full patient panel, have your visits, accounted for, but then to be able to address them on your own time. You could still sit down and have dinner with your family. You can still, potentially travel for the holidays and go spend time with people and still be able to address the concerns, do your job, and actually save yourself a whole lot of time. Your patients, as long as they're aware what your timeline looks like, you say, hey, I will respond, at this appropriate time. And then there's your answer. You kind of eliminated a lot of the back and forth that generally tends to take up most, at least in the primary care world. What usually happens is
all of us. Same thing with urologists, but take it even one step further, and we talk about this on the interviews, is that so the model, or not the model, but the perspective that you're talking about healthcare lags behind.
Mhm.
So in my lifetime, I never thought that I would never have to go to a bank again to
Yep.
deposit a check, or shop online, or having to go to a store to try on clothing. And so, taking that and I I can't believe I think this way now, but patients, we're the old model is we want patients to come to us as physicians. That's traditionally how it is. We are, I don't want to use the word spoiled, but it's just the way things have always been. You sick patient have to come to me and sit in my office for hours and, for a 10-minute visit. Well, now we know that we can do this in business and banking and shopping and retail, that the patient is the consumer. And the consumer, the patient, wants to have health care come to them in
Yep.
their home. We used to have house calls where physicians would go to patients' homes. That went away. But now we can have virtual house
Mhm.
calls. So the whole paradigm is really shifting, and it's very difficult. Patients get it, but physicians are lagging behind.
Absolutely. And I will say there are some times where it does help to have people come in person. But I
Sure.
feel like those instances are, well, one, fewer and farther between as technology improves, but also then as you kind of get more familiar with your practice and your clinical needs, you can triage those appropriately. And instead of having all of the back and forth that comes with it, the chaos of they call the PSR who gets, or the front office who gets transferred to the MA that then gets deployed to the nurse on triage, who then finally the message ends up on your desk. And here we go all day trying to just answer, do I need to change my blood pressure medication? Yes or
Right.
no? And it's like,
Well, and I don't want to, I mean, because I'm a telehealth champion, I tend to like go right into that. But yeah, the way that things work the best, at least right now, is what we say the hybrid model. So you
yep.
have to be able to say no. This is not appropriate. You need to come in to see me. I need to touch you. I need to hug you and kiss you and put my hands on you. I need to do a rectal exam. Whatever it is that you need to come in to feel your abdomen, listen to your heart if it's not working. The physician, the resident, the student needs to be able to say no, and the patient has to come in. Um, so we're going to jump ahead to the future a little bit and ask you a question because we're heading into 20 minutes. One of the things that I'm also interested in younger physicians is the concept, really, digital health is so much more encompassing now than just video visits. We have remote patient monitoring, RTM, which is remote therapeutic monitoring, and now we have, which has been around for a long time, virtual reality, augmented reality, artificial intelligence, and the metaverse. And these concepts are futuristic. I say that, but the future is now. And so I'm wondering, Jaclyn, what your thoughts are about those concepts in healthcare.
Yes, and it's funny since we first started, or at least when we first mentioned this question when I was kind of reading beforehand, I've actually thought of more ideas, even just coming up with them. But for example, I think how we're already just even in a very peripheral sense starting to see this deployed is remote diagnostic testing, at least in the primary care land. Instead of for very simple examples. I can, instead of having my patient, like you said, come into a facility to have a sleep study done to determine if they have sleep apnea, I can order a home sleep study. All of the stuff gets sent to them. They are instructed with how to detect, all the electrodes and how to place everything and how to position themselves in their own home, in their own bed. They sleep. And then all simultaneously, they're being watched and monitored from remote settings in terms of watching their blood pressure, watching their vital signs, watching their oxygen saturations. And then they package everything up in the morning and they mail it. And then I get a report and no one left anywhere. And we've been starting to see that happen with EEG testing. We've been seeing that with stress testing. It's sleep studies are the only one that are really well covered at this point, and I'm sure we'll talk about insurance coverage at some point. But that's been very cool. On a more kind of what I am excited about, or what I kind of envision from a virtual reality standpoint, I feel like there's a lot of potential, and so much of that I still haven't quite untapped in my head. But one of the ones I was thinking about, which would really be beneficial, especially as a not surgical specialist, so many of my patients come to me for preoperative clearance and preoperative evaluation, and then ask me all sorts of questions about surgeries that I have never done and will never be trained to do. But if we can allow, I would envision like an unbelievable virtual reality video of how we can guide through human body education and how we can almost like I don't know if people in this audience have ever watched like Osmosis Jones or like Magic School Bus when they used to take you on these journeys through your blood vessels, to be able to really show patients what we're trying to teach them, as opposed to my really low par drawings on my scrap paper to try and educate. That it would be unreal to be able to kind of drive them to their liver to explain to them this is what a cirrhotic liver looks like and this is why it matters. And to be able to do that would be a great educational tool. They've shown studies that people who can have a guided imagery therapy session or really a very deep dive into what the actual procedures they're going to undertake looks like, they've shown that they have better postoperative outcomes. They have shorter healing times. They have better full opportunities for recovery and even better opportunities for growth beyond where they were before. On a more, I guess, for my specialty level, I feel like from the psych standpoint of things, to be able to offer PTSD and exposure therapy and all sorts of extra tools from a cognitive behavioral therapy standpoint, that could be game changing for people who right now have to drive very, very far distances to get any level of psychiatric care. And if we could do that all remotely, for example, I had a patient the other day who she was in, just 15 years old, in a terrible car accident, now has 14 compression fractures, is literally 2.5 inches shorter than she was last year. She will no longer ever be able to ski, hike, do any of the things that used to bring her joy, and let alone she now is terrified of getting in a car. If we could create some sort of augmented reality, virtual reality to help coach her through the anxiety, through the stress, through the fear response that her body automatically, initiates every time she gets anywhere near a vehicle, that would change her life. Because right now she's a 15-year-old stuck at home doing homeschool. Because
Right, right. And I have to tell you, Jaclyn, that everything you just said
Mhm.
is already happening.
I would love to see
It's
that.
already it's already out there in
Mhm.
all of those examples that you just mentioned. It's just getting it into the hands of physicians like yourself that have open minds to and I do agree. I think education is a huge component for patients and physicians. I was at a conference a couple months ago where I put on the goggles and implanted a battery in somebody's ankle um, for pain relief. So it was a type of stimulation. And I've done many of these in the past, so I didn't really need to utilize the goggles. But for residents who are just learning
Oh yeah.
to do procedures, whether it's a robotic prostatectomy or whatever procedure it is, these it's happening right now as a tool. So it's the next level of simulations rather than what we have now. This is, the metaverse. The metaverse has a bad rap because it seems to uh, bring people to Facebook and Mark Zuckerberg, but it's not that. The term metaverse was started in 1992, 30 years ago. Um, and now it's really starting to happen. And I bring this up to you because you are a resident and you will be driving the metaverse bus, the
Hmm.
metaverse in healthcare. And I say, rather than Mark Zuckerberg telling you what that should look like, that Dr. Jaclyn Israel should tell Mark Zuckerberg how that's going to look like, because you have the experience with your patients to know. Um, the other quick thing we'll talk about, and then we'll wrap this up, is reliable broadband and internet in rural areas. You talked about that a little bit. What's your experience with that?
Yes, I think that's one of the few kind of hurdles, at least in my day to day, that has been really limiting. We don't have great service access in Maine. We have one internet provider for the whole state, and if they're not where you're at, you're done. And so that's been a big issue because I feel like telehealth, it was really, like you said, designed, or at least the idea came into place with rural areas in mind. And here we are still not able to get telehealth to a lot of rural areas. And
Right.
that is definitely a limiting factor. If you don't have service, then this is all for naught. And even if you do manage to also have the technology, you can't use it, or vice versa. The access to the technology, we don't have any. I don't think there's a single store within 2 hours of me that would sell any sort of screened device. The closest Walmart is an hour and a half away.
Yeah.
That's about it. So beyond service, technology, all of those things, some of my patients have got it, but a lot of them still don't.
Right. Right. So that's been on the radar for the past few years. The pandemic has really highlighted that. And I think the government, not I think, the government for sure recognizes that hurdle. And I'm going to leave with one last thing, that a positive note for telehealth. So, hot off the press, the omnibus bill just passed
Yep.
the Senate and the Congress, the House, and buried in that, like page 3,740, is our telehealth, a list of telehealth. They're not permanent changes, but extensions beyond the public health emergency that will go to at least 2024. And those, and I will be talking about that on my Beyond Telehealth and some of these podcasts. But the good news is that for CMS, and hopefully the private payers will follow, that patients can continue to do this from their home, which is huge. That's a big, so the geographical site will still be in place. And we're going to continue to get paid for these services.
Right.
So you talk about burnout, physicians that do a lot of patient care for nothing. That takes a lot of time, and it's been very important for us to be sure that we are going to get paid for taking care of our patients. It's really important.
Absolutely.
So,
Before
yeah.
COVID, that was half the limiting factor. If you weren't getting reimbursed for the same amount of work, what's the incentive there? You still have to run a functioning business. Whereas if we can continue to do that and still be compensated the same way, makes perfect sense to me.
It's a win-win for everybody, I
Right.
think. Yeah, for sure. Well, let's end here, and we can continue on as you go through your residency and see where you take telehealth. I'm excited and glad to meet you, and thank you for making the effort in the Stormageddon, as we call them.
Yes. No, thank you for having me. This has been fun. I'm excited to see where we're at in a few years' time as well. I think there's a lot coming down the pipeline for sure.
All right, Jaclyn, stay on. I'm going to end the broadcast. Thanks.
All right. Thank you.
All right, thanks.